Welcome to this explainer. Today, we're basically going to completely rethink the relationship between diabetes and cardiovascular risk. We usually look at these as parallel tracks in a patient's health, but as we're about to see, they're so deeply intertwined that they really demand a radical shift in how we approach treatment.
Okay, let's just dive right in with a pretty shocking reality. A patient with type 2 diabetes who has absolutely no history of a heart attack can already carry the exact same cardiovascular risk as someone who has already survived one. Actually, let me emphasize that. Not a similar risk, the exact same risk category. This is the paradigm-shifting concept that frames literally everything we're going to discuss today.
Think about it. The second you write type 2 diabetes on a patient's chart, you might already be looking at someone who needs to be treated as if they're in a secondary prevention scenario, meaning we have to treat them as if the heart attack has already happened just to prevent the next one. Treating diabetes and high cholesterol as two separate sequential boxes to tick, it's entirely backwards. So why is this? Let's look at the biology. Diabetes doesn't just add a risk factor alongside cholesterol, it fundamentally changes the cholesterol itself. Insulin resistance is an incredibly active process. It physically reshapes a patient's lipid profile, driving a much higher atherogenic risk, meaning a higher risk of plaque buildup in the arteries, even when their total LDL numbers look completely unremarkable on a standard lab slip. We actually call this the dyslipidemia trifecta, and it goes like this. Triglycerides go up, your protective HDL goes down, and crucially, the remaining LDL particles become smaller, denser, and far more easily oxidized. They become significantly more dangerous on a per-particle basis. This perfectly explains why a diabetic patient with a seemingly normal total LDL actually carries a massive cardiovascular risk.
And then, when you layer on the excess visceral fat that so often accompanies this, well, the whole situation just escalates. Visceral fat acts as a literal engine for chronic, low-grade inflammation. And this doesn't just impact the heart, it cascades through the entire system, affecting the liver, the kidneys, and even the brain. Diabetes, obesity, and dyslipidemia aren't three separate problems, right? They're one interconnected metabolic fire, and they demand a unified treatment strategy. Which brings us to the really crucial part, the 2025 ESC-EAS three-tier risk stratification framework. This dictates exactly how aggressively you need to treat. Moderate risk applies to younger patients with short disease duration, where we aim for an LDL below 2.6 millimoles per liter. High risk includes those with a diabetes duration of 10 years or more, targeting below 1.8. But it's really that bottom row we need to focus on today.
Now, what's genuinely wild about this is how easily a patient can slip into that very high-risk category. Simply finding early target organ damage like retinopathy in the eyes, nephropathy in the kidneys, or neuropathy in the nerves automatically elevates a patient with zero cardiac history to the absolute highest tier. This is a massive clinical trigger. It demands an incredibly aggressive LDL target below 1.4 and a mandatory 50% drop from their baseline.
But here's the million-dollar question. How do we actually hit that massive 50% reduction? Because getting below 1.4 is incredibly hard with statin monotherapy alone, which brings us to the biggest paradigm shift in current guidance. We are completely abandoning the old, slow, stepwise approach. Start a statin, wait a few months, recheck, maybe add another drug later. Current evidence says that leaves high-risk patients dangerously undertreated for way too long. The new paradigm? Early combination therapy right from the start.
For your absolute highest risk patients, the path is aggressive. It's immediate. You literally cannot be afraid to combine a high-intensity statin with ezetimibe right out of the gate. If you know mathematically that a statin alone isn't going to get them to that 50% reduction, combine them up front. And if targets are still missed, the toolkit expands. You've got PCSK9 inhibitors and newer agents like bempedoic acid or inclisiran. Now, what if they're statin intolerant? Because that happens, right? Well, newer tools like bempedoic acid are absolute game changers here. Because of how it's metabolized, it bypasses that notorious muscle pain and weakness signal entirely, while still effectively lowering LDL. It basically gives us a way to protect patients who previously felt like they were completely out of options. So, a question we get all the time in practice is this. Does it actually matter which high-intensity statin you choose, atorvastatin or rosuvastatin? While some regional data suggests rosuvastatin might have a slight edge in specific post-stroke populations, the broader consensus is pretty clear. The much more important decision is simply dosing aggressively enough and combining with ezetimibe early enough. Don't agonize over which specific statin brand is on the script, focus on the strategy.
Okay, so while that three-tier framework is your foundation, you kind of have to play detective here too. You need to look out for hidden risk enhancers. These can quietly reclassify a borderline patient into a higher, way more urgent treatment tier. Factors like a family history of premature cardiovascular disease, chronic kidney disease, metabolic syndrome, especially in women, or chronic inflammatory conditions. These require you to look closer and potentially escalate their risk category.
And speaking of those hidden enhancers, we have to talk about lipoprotein A. Current guidance is super clear on this. You need to measure this genetically determined risk factor exactly one time in every adult patient's life. Just once. Because it's tied to their genetics, the level won't really change over time. It won't show up on a standard lipid panel, but if it's elevated, it is an independent driver of risk that can easily tip a borderline patient right into a higher treatment category.
All right, let's bring this all together with a real-world application to see exactly how this framework changes your daily clinical practice. Imagine a 52-year-old guy. He's had type 2 diabetes for 12 years. He feels completely fine, no known cardiac events, but his recent routine screening shows early diabetic nephropathy with microalbuminuria, meaning there are tiny amounts of protein leaking into his urine. Under the old way of thinking, you might just, keep an eye on things or start a low-dose statin. But if we apply this new framework, it changes literally everything. Step 1, classify him. Because of his disease duration and that early kidney stress, which absolutely counts as target organ damage, he is immediately placed in the very high-risk tier. Step 2, the target. He needs an LDL below 1.4 and a greater than 50% reduction. Step 3, the action. This requires an aggressive, immediate start on combination therapy, high-intensity statin plus ezetimibe together, rather than waiting months to see what a statin alone might do.
Now I hear this a lot. You might be wondering, wait, won't statins worsen their glycemic control? It's a totally fair concern, and it's super common among patients and practitioners alike. And yes, it's true, high-intensity statins can modestly affect glucose levels, but the data is crystal clear on this. For a very high-risk diabetic patient, the massive cardiovascular protection far outpaces the modest glycemic effect. It is absolutely positively not a reason to withhold or underdose life-saving lipid-lowering therapy.
Of course, we've been talking a lot about pharmacology, but we absolutely cannot ignore the foundation. Dietary pattern optimization, consistent physical activity, weight management. These aren't just polite suggestions to tack on to the end of a visit as your hand is on the doorknob. They are crucial first-line interventions. They directly combat the root cause, the insulin resistance that is driving the dyslipidemia in the very first place. They have to work hand in hand with the medication.
So if you take away literally nothing else from our time today, let it be this. Diabetes and dyslipidemia are not parallel tracks. They are a singular, silent multiplier of cardiovascular death if they aren't recognized and attacked together. The actual biology of the disease demands that we see them as one interconnected metabolic thread. I'm going to leave you with something to ponder before you see your very next diabetic patient. Knowing what we now know, knowing that diabetes fundamentally alters the danger of every single lipid particle, are you still going to treat their cholesterol sequentially, waiting months and months to see if a single drug works? Or are you ready to target their true biological risk with combination therapy from day one? The science is clear. For sure, the next step is yours. Thank you for joining me for this explainer.